Hotbed Talk.
This piece is in two parts. This is part one.
My name is Glenn Murphy, and I'd like to welcome you to today's talk, Monitoring and Management of Neuromuscular Blockade. In particular, can we improve adverse outcomes related to residual block through better management of neuromuscular blockade? I think one of the biggest things we do as clinicians to harm our patients is leave them with residual block in the PACU. In fact, a lot of people who do research in this area agree. This was an editorial by Soren Bruhl which stated, in the United States, approximately 112,000 patients annually are at risk for adverse events associated with discharge from the operating room with residual neuromuscular blockade. Unfortunately, many of our colleagues don't believe this is the case. This was a survey that was sent to anesthesiologists in America and Europe and asked, do you ever see clinically significant residual block in your PACU? 80% of the European respondents and 90% of the respondents in the United States said they never see this in their PACU, which is remarkable to me because we see this every day in our PACU. And I think the reason people don't see this is because they're not using quantitative monitoring. In order to really detect this problem, you have to be using quantitative monitoring. It's sort of, if you don't take a temperature, you don't find a fever. You have to be using quantitative monitoring to detect this problem. So when a patient is getting into trouble in the PACU, oftentimes it's unrecognized. So I'd like to start by basically talking about how is residual block defined. Now, traditionally, it's defined as a train of 4 ratio of less than 0.7 using quantitative monitoring. That's what I was taught when I was a resident. However, if you look at data from since the 1990s onward, these studies show that you really need to achieve a train of 4 ratio of 0.9 or greater before you can safely extubate your patient. This is based on data that shows that subjects with train of 4 ratios less than 0.9 have an impaired hypoxic ventilatory response, pharyngeal dysfunction and airway obstruction, increased risk for aspiration, increased incidence of hypoxemic events, and a number of other events which we'll discuss in our talk today. Well, how common is residual block? Again, most clinicians think this rarely occurs. This is not the case. The first study was performed in 1979 by Vibby Milgenson and colleagues, and they found that 41% of their patients got to the PACU with residual block. Well, since that time, there have been over 100 studies performed showing that residual block commonly occurs. Somewhere between 30 to 60% of patients around the world get to the recovery room with residual block, a train of 4 ratio of less than 0.9. This is one of the more recent studies, a Recite US study. This was a prospective observational study looking at the incidence of residual block at 10 U.S. hospitals. They looked at relatively healthy patients undergoing abdominal surgery, and they measured train of 4 ratios immediately before extubation. In this study, they found that 65% of patients had train of 4 ratios less than 0.9 at the time of extubation, and 31% had train of 4 ratios less than 0.6, a pretty severe residual block. There were also Recite studies performed in Canada and China, which showed very similar findings. So we know from the data that's been published over the last 4 decades that a high percentage of patients get to the PACU with residual block. I think a more important question is, what is the clinical significance of this residual block? I think the best answer to this question comes from clinical studies where they actually look at patients when they get to the PACU, they put quantitative monitors on, determine whether they have residual block or not, and then carefully follow these patients to look for these adverse outcomes. Well, these adverse outcomes tend to fall into a couple different categories. Most of the data shows that patients with residual block have an increased risk of adverse respiratory events, such as hypoxemia, airway obstruction, and postoperative pulmonary complications. Patients with residual block have also been shown to have prolonged PACU length of stay, increased risk of ICU admission, and a number of unpleasant symptoms of muscle weakness. I'd just like to point to a couple of recent studies that have been performed looking at this issue. This was a study looking at the association between residual block in the PACU and adverse respiratory events. This was a multi-center study from Spain, which enrolled 763 patients from 26 centers. They measured train of 4 ratios when the patients got to the PACU. In this study, 27% of patients had residual block. What they found in their analysis was that patients with residual block were at significantly increased risk for these adverse respiratory events with an odds ratio of 2.6 and had an increased risk of need for reintubation in the PACU. Again, oftentimes we drop our patients off at the PACU, we go back to the operating room. We don't see these adverse events occurring in the recovery room. That's something our recovery room nurses do see. This was a similar study. It was a prospective observational study looking at risk factors for adverse respiratory events. they looked at 340 consecutive patients, and they looked at a large number of preoperative and intraoperative risk factors. Now, these adverse respiratory events are not uncommon. They occurred in 20% of patients. What they found in their analysis is that these adverse respiratory events were more frequent in patients who received muscle relaxants and in patients with a residual block. In fact, in their analysis, the single biggest predictor of adverse respiratory events was the presence of residual block in PACU. In fact, with an odds ratio of 6.4. So patients with residual block have a 6.5 times higher risk of having one of these adverse respiratory events in the PACU. This was a study that was recently published by Dr. Eicherman's group out of Mass General. This was a retrospective cohort study looking at the effect of residual block on hospital cost, ICU admissions rates, and hospital length of stay. Now, what's unusual for a retrospective study is they actually had quantitative data. They knew which patients had train to 4 ratios less than 0.9 in the PACU. And this was a pre-specified analysis of data obtained from over 2,200 patients undergoing surgery under general anesthesia. Now, in their study, 21% of patients had residual block. They found that these patients with residual block had a 3 times higher risk of having unplanned ICU admission compared to those without residual block. Residual block was not independently associated with hospital costs, but there were trends towards increased hospital length of stay in patients with residual block. Now, I'd like to switch gears a little bit and talk about neuromuscular monitoring. First, let's talk about peripheral nerve stimulators. Does the use of a peripheral nerve stimulator improve outcomes? Well, in the 1990s, there were several small studies performed looking at this issue. This is an example of one of the studies. In this study, 39 patients were randomized to train to 4 monitoring with a peripheral nerve stimulator or no monitoring. The no monitoring group, 47% of patients had residual block versus only 15% who were monitored with train to 4 stimulation mode on the peripheral nerve stimulator. Again, it's important to recognize that the definition of residual block in this study was a train to 4 ratio less than 0.7. Again, that was the standard at this time. So you can imagine the number of patients having train to 4 ratios less than 0.9 was significantly higher. What these studies in the 1990s showed were that the use of peripheral nerve stimulators reduced but did not eliminate the risk of residual block. And the reason for this is shown in this slide here. This was a study where they looked at the ability of anesthesiologists to detect fade using train of 4 stimulation at various levels of neuromuscular blockade. What these investigators found was that clinicians were unable to detect fade unless train of 4 ratios were less than 0.4. So you could actually have a train of 4 ratio as low as 0.5 and see no fade with train of 4 stimulation. So 4 strong twitches with no fade. And you can still have a train of 4 ratio as low as 0.4 or 0.5. This is the most recent study that was published looking at the use of peripheral nerve stimulators. Now, a lot of clinicians think in the area of Sugammadex, we don't need to use a peripheral nerve stimulator. Well, this study comes out of Japan. And in Japan, the use of neuromuscular monitoring is not part of the culture. They don't use peripheral nerve stimulators. In fact, when using Sugammadex, it's typically dosed if the patient is spontaneously breathing, you give them 2 milligrams per kilogram, and if they're not, you give 4 milligrams per kilogram. Again, we know patients can actually have no twitches and be spontaneously ventilating because the diaphragm is one of the muscles that comes back very early. What they did in this study was looking at the risk of residual block using neostigmine for reversal agent and Sugammadex for reversal agent in the absence of using a peripheral nerve stimulator. With a neostigmine group, about a third of the patients had residual block. But what's interesting in the Sugammadex group, the risk of residual block could be as high as 9.5% if you use Sugammadex in the absence of a peripheral nerve stimulator. Again, we know with a peripheral nerve stimulator, this risk could be about 1 to 2% at the most. So again, even if you're using Sugammadex, you should be using a peripheral nerve stimulator. Let's move to the next question. Does quantitative neuromuscular monitoring reduce the risk of residual block or impact clinical outcomes? Now again, quantitative monitors are devices which actually measure and give us a number of what the weakness is. Again, a train to 4 ratio typically between 0 and 1 or 0 and 100%. Now for a long period of time, the only quantitative monitor that was available to us as a standalone unit was the TOF watch. Now, it was thought when the TOF watch was released, this would be widely accepted in clinical practice, and it really wasn't. The reason was this is a relatively hard monitor to use. The hand had to be very specifically secured. The thumb had to move in exactly the same way every time when the ulnar nerve was stimulated. The device had to be calibrated. There had to be a period of signal stabilization. It was a very hard device to use, so it never really caught on in clinical practice. However, there are now some second-generation monitors that are much more easy to use for clinicians and probably give more accurate and reliable results. For example, this is a three-dimensional acceleromegraphy device called the TOF-scan that was recently FDA approved. Now, the advantage of this device is that it can sense the movement of the thumb no matter what direction it moves in. And again, when we stimulate the ulnar nerve, oftentimes the thumb will move in different directions. And with a TOF watch, when that happened, you'd get inaccurate data. So this device may give you more accurate information. This is a study our group did where we compared the TOF scan to the TOF watch SX. And on one arm, we put the TOF watch, and we went through all the elaborate setup. Again, we secured the hand, we made sure the thumb moved in the same direction every time, we calibrated the device. The other side, we put the TOF scan on, and we just pressed a button to get the data. We found that the TOF scan gave us data was very comparable to the TOF watch with the elaborate setup. So again, I think for these monitors to be routinely accepted, they have to be about as easy to use as a pulse oximeter. We want to just be able to push a button and get data. And the TOF scan seems to be able to provide that type of information. This is a StimPod, another three-dimensional acceleromegraphy device that's been released into clinical practice. Again, we need some more data on this device to really understand its accuracy and reliability. Now, recently, there have been two FDA-approved portable EMG monitors. Now, the big advantage of EMG technology is twofold. First, it appears to be the most accurate technology. It compares most favorably with mechanomography, which is sort of the gold standard technology. So it tends to be a very accurate type of, provides very accurate data. The second big advantage of using EMG technology is that the arms can be tucked to the side. Remember, it's only measuring electrical activity of muscle, not movement of the muscle. So this is a big advantage in our clinical practices because very often our patients' arms are tucked to the side. This is one of the devices, the tetragraph. We're actually doing some clinical trials with this at our institution right now. This is another similar device, the Twitch View. Again, it has a strip of electrodes you put on the hand, you plug it in, you push a number, and it gives you train of 4 data. So these devices are very simple and easy to use and appear to provide reliable data. Now the question is does the use of these monitors reduce the risk of residual block or improve clinical outcomes? Well, we know from a number of previous studies that have been published that if you use a quantitative monitor, you can significantly reduce the risk of residual block. Well, we did a study looking at this. Now, we know patients oftentimes complain of taking a long time to wake up from anesthesia. And oftentimes, this is related to symptoms related to residual block. If you ask patients, what do you mean by a long time to wake up from anesthesia? You oftentimes hear, well, I was just tired. I couldn't keep my eyes open. I just felt so weak. Oftentimes, that long time to wake up from anesthesia is symptoms of weakness. So our hypothesis in this study was the use of the TOF watcher, which is acceleromegraphy monitoring, by reducing the incidence of residual block should also maybe reduce these unpleasant symptoms related to muscle weakness. In this study, 155 patients were randomized to the TOF watch or standard peripheral nerve stimulator. In the control group with the standard peripheral nerve stimulator, they got extubated when they met all standard criteria and they had 4 strong twitches without evidence of fade. In the TOF watch group, it was the same thing, but they had to achieve at least a train of 4 ratio of 0.8 before the patient was extubated. Then when they got to PACU, we looked whether they had residual block or not, and then we carefully examined them for 16 symptoms and 11 signs of muscle weakness that might be related to residual block on PACU arrival in 20, 40, and 60 minutes later. And then at the time of discharge, we had them assess their overall quality of recovery. How would they evaluate their quality of recovery? Well, what we found was that the risk of residual block was significantly less when we used the TOF watch, which isn't surprising from what we know from previous data. We also found that the number of symptoms of muscle weakness in the PACU in 20 and 40, 60 minutes later was significantly less in the group that got monitored with the TOF watch. The most common symptoms patients seemed to complain of was general weakness and visual symptoms. But most importantly, at the time of discharge from recovery room, the patients who were monitored with the TOF watch reported that their quality of recovery was significantly better if they got monitored with a quantitative monitor. So we can not only reduce the risk of residual block, but potentially improve outcomes. This is a very similar study. Again, in this study, our theory was the use of the TOF watch by reducing residual block may also reduce the risk of adverse respiratory events that might be related to residual block. So in this study, 185 patients were randomized to either receive a peripheral nerve stimulator or the TOF watch. And again, the study design was very similar, extubated at similar criteria. And then we followed them closely from the time the tube came out in the operating room to the time they were discharged from the recovery room for adverse respiratory events. Now, what we found in the group that was monitored with the peripheral nerve stimulator, 30% of those patients had residual block versus only 4.5% who were monitored with a TOF watch. Now, one of the really vulnerable areas, I think, of patients getting into trouble is the time between the patient getting extubated in the operating room and getting to recovery room. I think that's a period of time where people can get into trouble. What we found when the group that was monitored with the peripheral nerve stimulator, 21% of those patients during transport from the operating room to recovery room had severe hypoxemic events, and 11% of those patients had episodes of airway obstruction. Now, when we looked at the group that was monitored with the TOF watch, 0% of those patients had severe hypoxemic events, and 0% of those patients developed airway obstruction. We also found that the group that was monitored with the TOF watch, in that group, the incidence, severity, and duration of hypoxemic events was significantly less. So again, not only by using this monitor can we reduce the risk of residual block, but we may be able to reduce the risk of adverse respiratory events associated with residual block. So why don't clinicians use quantitative monitors? The data is pretty convincing that we can benefit our patients by using this. If you look, only about 10 to 20% of U.S. anesthesia departments actually have these monitors. It's much more common in Europe. And I think the reason was, as we talked about, these first-generation monitors were very difficult to use. They required elaborate setups, time to place and calibrate the monitors. And this has occurred at the start of the case where we're very busy, and we don't have time really to focus on this. I think a lot of people perceive the results as unreliable because there's really a learning curve to using the TOF watch. I really think you have to use it 50 or 100 times if we really start getting accurate and reliable data. So people would put it on, they get a couple goofy numbers, and they would say this monitor doesn't work. Surveys have also shown that clinicians are overconfident in their knowledge and ability to manage the use of neuromuscular blocking agents. People think, well, this doesn't happen in my practice. My patients have residual block. I do fine without this monitoring. I don't need it. And again, as we talked about, many clinicians believe the residual block is a rare event, so why use quantitative monitoring? Well, I think one of the ways we can get people to change their practices is via practice standards or guidelines. I think oftentimes we need those to really get people to change what they do. If you look around the world, many countries have very specific practice standards or guidelines related to neuromuscular management, what kind of monitoring is used, how you should dose, reversal strategies. The United States, really, the only thing the ASA says is that you should have availability of peripheral nerve stimulator. We don't have these type of guidelines. A number of researchers in this area basically became frustrated with this and decided to get together and put together a consensus statement on the use of neuromuscular monitoring. This was recently published in Anesthesia and Analgesia. What these authors concluded was that quantitative or objective neuromuscular monitoring should be used whenever we give a muscle relaxant. However, the panel recognized that replacing conventional peripheral nerve stimulator devices with quantitative monitoring equipment will take time and education. During this interim period, the use of a peripheral nerve stimulator in any patient receiving a muscle relaxant is mandatory. They also stated that professional organizations should develop practice standards and guidelines detailing how to best monitor and manage perioperative administration of muscle relaxants. The last thing I'd like to talk about are recent studies looking at the effect of reversal strategies on clinical outcomes. There have been a number of interesting studies looking at this. I think it's very important to emphasize that we should always reverse our patients unless we have a quantitative monitor that shows us that the patient is fully recovered to a train to floor ratio of 0.9 or greater. Oftentimes clinicians think, well, it's been 2 hours, it's basically the muscle relaxant's recovered, I don't need to reverse. That's absolutely not true. Sometimes with a single dose of muscle relaxant, you can have basically an effect that can last 5, 6, 7, 8 hours. And again, we don't know, there's such variability in spontaneous recovery times. So it's important that we should always reverse our patients. There have been several recent studies that have looked at this. This is a study that came out of Vanderbilt looking at the association between the use of muscle relaxants, reversal agents, and the risk of postoperative pneumonia. In this database study, they found that patients who received the muscle relaxant had a significantly higher risk of postoperative pneumonia. But more importantly, they found that patients who received the muscle relaxant and who were not reversed had a 2.3 times higher risk of having postoperative pneumonia. So pretty interesting data, and it's consistent with what's been previously published in the literature. Shortly after this study was published, another study was published in Anesthesia and Analgesia was very similar. Again, they were looking at the association between muscle relaxants, reversal agents, and morbidity and mortality after surgery. Now, this was a large study, a retrospective study of over 11,000 non-cardiac patients from 5 VA hospitals. In this study, about 9,000 patients received a muscle relaxant. Of these 9,000 patients, 2,000 of the patients were not reversed. Now, the primary endpoint in this study was respiratory complications, which they defined as failure to wean, reintubation, or pneumonia. Again, rare events, but again, very significant adverse events. What these investigators found was that patients who received a muscle relaxant had an increased risk of these respiratory complications. But more importantly, they found that patients who received the muscle relaxant and who were not reversed had a significantly increased risk of these respiratory complications and a marginal increase in 30-day mortality. Again, further data showing we really need to be reversing our patients. This is another study that was published, a single-center study, which was comparing complication rates in patients who received muscle relaxant reversal versus those that did not. This is a retrospective analysis of all patients having non-cardiac surgery between the years 2005 and 2013. And they looked at the incidence of major complications, which they defined as things such as heart attack, congestive heart failure, unplanned ICU admissions, and then minor PACU complications, which they defined as things like hypoxemic events and airway obstruction. Now, the incidence of these major complications was uncommon but not rare, 2.1%, and the minor complications occurred in 35% of patients. What they found in their analysis was that patients that were reversed versus those who received neostigmine reversal had a higher risk of any major complication, 6.1% versus 1.7%, which was driven primarily by an increased rate of reintubation and an increased rate of unplanned ICU admission. Again, further data that we really should be careful about reversing our patients. Now, I'd like to talk a little bit about Sugammadex, because there have been a couple interesting studies that were recently published. Now, this study was just published in Anesthesiology. It was looking at the effect of Sugammadex versus neostigmine on the incidence of postoperative pulmonary complications. Now, this study comes out of Dr. Ketterpal's group, the EBPOM group, which does a lot of very high-quality database investigations. Now, this was a multi-center observational matched cohort study involving 12 hospitals. They looked at adult patients undergoing elective inpatient non-cardiac surgical procedures who received a muscle relaxant and a reversal agent. And this was between the years 2014 and 2018. The composite primary outcome was major postoperative pulmonary complications, which was defined as pneumonia, respiratory failure, or other pulmonary complications, which they specifically defined in this study. In this study, over 22,000 patients who received Sugammadex were matched with over 22,000 patients who were given neostigmine. And what these investigators found in their analysis was that Sugammadex use was associated with a 30% reduced risk of pulmonary complications, a 47% reduced risk of pneumonia, and a 55% reduced risk of respiratory failure compared to neostigmine. This is another study that was just published in the British Journal of Anesthesia. Now, this was a randomized trial looking at the use of Sugammadex and neostigmine and its effect on the incidence of postoperative pulmonary complications. They looked at a high-risk group of patients, older patients undergoing prolonged surgery. Now, in this study, they enrolled 200 patients over the age of 70 who were having surgery lasting greater than 3 hours. In the study, at surgical closure, patients were randomized to receive either Sugammadex 2 milligrams per kilogram or neostigmine 70 mics per kilo for rocuronium reversal. And their primary endpoint was the incidence of postoperative pulmonary complications. What the investigators found was there was no significant difference in the primary endpoint of postoperative pulmonary complications, despite a signal towards reduced incidence for Sugammadex. These postoperative pulmonary complications occurred in 33% of the Sugammadex patients versus 40% of the neostigmine patients. Now, what the investigators acknowledged was that the study may have been underpowered to detect this primary outcome. So maybe if they enrolled more patients, this would have been a statistically significant difference. But they also found in exploratory analysis that there were fewer 30-day hospital readmissions in the Sugammadex group compared to the neostigmine group, 5% in the Sugammadex group versus 15% in the neostigmine group. So what can we say in conclusion with the data we know from recent published trials? Residual block is a common complication after anesthesia and surgery and occurs in between 30 to 60% of patients. We know from studies that have been published over the last several decades that patients with residual block are at increased risk for adverse respiratory events, a number of unpleasant symptoms and signs of muscle weakness, prolonged PACU length of stay, postoperative pulmonary complications, and unplanned ICU admissions. Quantitative monitoring can reduce the risk of residual block and associated complications. We could seriously consider the use of quantitative monitoring in our clinical practices. We know from studies that failure to reverse the effects of muscle relaxants increases the risk of postoperative pneumonia, rates of reintubation, unplanned ICU admissions, and mortality. Recent studies have shown that the use of Sugammadex has been documented to reduce the incidence of postoperative pulmonary complications. However, further studies are really needed to examine this question. I think most importantly, careful management of neuromuscular blockade is required in order to optimize patient safety and enhance recovery. Thank you so much, and I'd like to open it up to questions now.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.